The organizer for asking me to join this conference. I have just landed an hour ago, and thanks to the very efficient for transportation. And my apologies because I should have participated in the whole meeting. I want to give a very brief background about this Asia Pacific Neurogastro Foundation course. So that happened actually a year ago. So we wish that we can develop a platform to develop the young GI fellow community so that we can have a platform for both training as well as networking for our future leaders in the area of neurogastro as well as functional GI disorders. So that's the background of this foundation course. And we are very delighted to invite friends from America to join this Asia Pacific course as well. So I did not expect to speak in this foundation because I asked the organizers to invite only young fellows to speak. So I'm probably not young enough to be qualified, but actually they have a title that nobody is willing to talk, and that's why I'm here to talk about this. So for the next 20 minutes or so, I'm going to talk about psychological factors in DGBI, and we will put emphasis on stress and behavioral influences. So I would like to start with this schematic diagram illustrating the quantitative mechanism of DGBI. So basically, this is a biopsychosocial model involving genetic physiological factors that happens in early life, like genetics, upbringing, as well as environmental factors like childhood adversity. And there are also a number of external factors as well as intrinsic factors that leads to a variety of psychosocial factors that contribute to the occurrence of physiological disturbances involving motility, sensory dysfunction, as well as a variety of physiological dysfunctions, which leads to development of DGBI. And also psychological and social factors will also affect the illness behavior as well as health-seeking behavior of these patients, and this will affect the outcomes. Our study shows that there is a strong association between early life adversity as well as abuse history and the future risk of DGBI. And also in the longitudinal study, one found that in the community setting, there is actually more than 6 times increase in the risk of developing functional dyspepsia among communities with anxiety disorder. So this is a very important data suggesting the chronological association between DGBI and anxiety disorder. And at the physiological levels, we also find that there are similarities between patients with DGBI and patients with anxiety or depressive disorders, like abnormal HPA axis as well as serotonin responsiveness among these two groups of patients. And at the genetic levels, we also find some similar findings with a higher level of G protein or SERT gene polymorphism in patients with DGBIs as well as anxiety or depression, suggesting at the genetic, physiological, as well as epidemiological levels, there are strong association between these two categories. So, you may wonder that this kind of association may be more common in specialist or tertiary care setting because of referral bias, but in fact this is not the case. These are the 2 studies that we performed quite early on in Hong Kong, which is a community-based studies, including 2,000 subjects separately in 2 different separate community-based studies, and we find that patients with functional dyspepsia symptoms is associated with significantly higher prevalence of depression as well as generalized anxiety disorder with an odds ratio of more than 3. So this is highly significant. And in another study, we find that patients with irritable bowel syndrome, actually they have a much higher likelihood of having concomitant symptoms of generalized anxiety disorder. So this cross-sectional data suggests, again, a very strong association between anxiety, depression, as well as DGBI, even at the community care setting, in addition to tertiary care setting. So in fact, if we are focusing on the symptomatology of DGBI, we find that psychological stress plays a particular role in the pain component of patients with DGBI. So we have a variety of GI symptoms like diarrhea, indigestion, but pain is the important symptom that is more strongly associated with psychological distress. So this is a systematic review, reviewing more than 300 articles, trying to see the association between psychological distress as well as the other factors with the association with pain. And we find that the single point cross-sectional association between pain with these factors are significant in both adults and pediatric patients. But if we just focus on ongoing persistence of pain symptoms in these patients, we find that psychological disorders and stress are the two most important factors that draw the association between pain and in this group of patients, suggesting that psychological distress will contribute to the persistent chronic pain component in patients with DGBI. So what are the physiological bases? Well, in fact, we find that visceral hypersensitivity is the most important mediator or mechanism that link anxiety, depression, as well as in patients with DGBI. So I illustrate this with an example in GERD patients. So traditionally, when we talk about DGBI, we are referring to patients with functional dyspepsia and irritable bowel syndrome. But in fact, even in gastroesophageal reflux disease, we also find similar association. So this is a comparison among four different groups of subjects. Reflux hypersensitivity, functional hyper. So these two groups are more regarded as functional esophageal disorder. Whereas for non-erosive reflux disease means that there is abnormal esophageal acid exposure, suggesting a genuine abnormal acid reflux in this patient. But we noticed that when all these three groups of patients, when they are compared to asymptomatic controls, all these three groups shows evidence of lower pain threshold, or what we call visceral hypersensitivity. And we also find that these three groups of patients, even including genuine GERD patients, they also have high anxiety and depressive scores. And also, when we compare these with individual anxiety and depression evaluation, we also found similar findings, suggesting that visceral hypersensitivity is strongly associated with anxiety and depression. So what is the central mechanism? In fact, there are a number of functional MRI brain studies showing that there might be a few factors in the central nervous system that play a role for this association. So this is a quantitative meta-analysis summarizing various neuroimaging studies, and we find that patients with irritable bowel syndrome is characterized with the excessive or abnormal emotional arousal to pain stimulation, as well as abnormal modulation at the central level about endogenous pain. But if we focus on visceral afferent signals, there is no significant difference between IBS patients and normal control, suggesting that this pain component in IBS patients is more strongly associated with central pain modulation rather than peripheral processing of the pain signals. And we also find that these IBS patients also have heightened excessive reactivities to stress in their HPA system. So suggesting that apart from abnormal pain modulation and emotional arousal, there is also a hyper-responsiveness of the HPA axis in response to pain. I also want to illustrate to you from a different perspective and see how psychological stress contribute to emergence of functional GI symptoms. In fact, immune activation could be another mediator. So this is a study done in Singapore, which is a small pilot study, but illustrating that how stress can contribute to emergence of GI symptoms through immune activation. So this is before military training, and this is after combat military training, so you can see a significant increase in the emergence of GI symptoms. So I can imagine that, military training in Singapore is really, really tough. You can see for those patients, for those soldiers with emergence of functional GI symptoms, with these scores, they have a higher anxiety, higher depressive, and higher stress scores. So this is a strong correlation between psychological distress as well as the emergence of GI symptoms. And also, these patients after military combat training, they have immune activation as evidenced by higher levels of interleukin-6 as well as tumor necrosis factor alpha, suggesting that after stressful event, the immune activation will also occur, and it is associated with the emergence of anxiety, depression, as well as functional GI symptoms. So this is for immune activation. But more recent data also suggests that dysbiosis or microbiota also act as a mediator or participate in this psychological stress and DGBI model. In fact, there are many ways that dysbiosis and gut microbiota can contribute to the pathophysiology. Well, first of all, when there is psychological stress through various mechanisms, immune activation or neurological pathways, there will be a change in permeability of the epithelium, leading to increased access as well as increased translocation of gut bacteria into the circulation. And also these metabolites by this dysbiosis will also be more accessible at the central nervous system, and many of these neurotransmitters or short-chain fatty acids can actually pass through the blood-brain barrier that cause a direct impact on the central nervous system. And also at the peripheral level, through a bidirectional effect, the vagus nerve also provides a communication pathway in the gut-brain axis as well as the brain-gut axis. And last but not the least, these processes also is associated with activation of HPA-Ss, and HPA-Ss activation leads to increase in stress hormone production and further increase in the intestinal permeability, and also this forms a vicious cycle. So nowadays we believe that gut microbiota also acts as a mediator between the psychological distress as well as DGBI. So going back to clinical practice, so how can we facilitate to have early detection? Because early detection and intervention is very important. And these are the common tools that you may refer to when you need to screen the patients in a busy clinic setting. So all these questions there are very short and concise, which consists of about 9 or 12 questions, and this can be readily administered by the nurses as well, and even self-administered by your patients. And this is a very valuable tool for the preliminary assessment. I'm not talking that you should treat all your DGBI patients as MAD patients, but I think early intervention would be very important for these patients. So far I've talked about psychological stress, and how about sleep? In fact, sleep is part of the stress. If it is impaired either in terms of the duration of sleep or quality of sleep. So sleep deprivation will lead to a variety of physiological dysfunctions like dropping salivary production, decrease in swallowing actions, as well as reduction in the physiological motor activities of the stomach, as well as the rest of intestines. So all these dysfunctions will lead to sensory motor dysfunctions, which serve as the basis for further development of DGBI. And at the same time, stress can also disrupt the sleep by various mechanisms, and as a result, sleep deprivation itself serves as a form of chronic stress, and this will further lead to a variety of physiological dysfunctions, neurohormonal dysfunctions, and as a result, it leads to some clinical associations like emergence of daytime reflux symptoms, increased association with functional dyspepsia, as well as irritable bowel syndrome. And that's why sleep quality and sleep quantity should be assessed in patients with DGBI. And in recent years, actually I find quite a significant proportion of DGBI who are actually suffering from obstructive sleep apnea, which is quite common in this part of the world, regardless of the body weight, because in general, our anatomical structure, the jaw structure is smaller than our Western counterparts. And that's why even for normal weight patients, they are also susceptible to obstructive sleep apnea. So I would suggest you to have a quick screening about this, especially if there is sleep disturbance or there is nocturnal GI symptoms. Then screening for OSA may be useful for this group of patients. So, well, usually we advise the patient to avoid this and that, including dietary avoidance. And a minute ago, Victoria shared with you how dietary modification can help DGBI. But in the real-life clinical setting, well, excessive avoidance of dietary can serve as a stressor. So that's why for long-term management, I won't overemphasize dietary avoidance or modification. So this serves as a diagram illustrating to you dietary avoidance itself can serve as a stressor that aggravates functional GI disorder. For example, dietary modifications, avoiding even for elimination diet as well as some of the dietary modification. This will also aggravate the fear because the patient needs to be more obsessive and also more avoidant. With further restriction on the volume and variety, this will lead to weight loss, nutritional deficiency, and nowadays there is an evolving concept for a subgroup of patients with functional dyspepsia. We call it avoidant restrictive food eating disorder. This is actually a gray zone overlapping between functional dyspepsia and anorexia nervosa, which is typically more commonly seen in female patients. And this reduction in the calorie intake and reduction in body weight will lead to further modification of the gastric function, and this serves as a vicious cycle. So the poorer the stomach accommodation, motor dysfunction, and sensory dysfunction, it further aggravates the dietary avoidance and the fear, and that's why this is served as a vicious cycle. So how should we deal with it? So as I've mentioned, early detection and intervention is the key. And we often think about medical treatment, and this is a summary of various psychotropic agents or neuromodulators for management of DGBI. So, well, you can see I have highlighted those squares with positive evidence suggesting the efficacy, and you can see tricyclic antidepressants are the most evaluated drugs with consistent efficacy for pain reduction in patients with functional dyspepsia, irritable bowel syndrome, and bronchitic chest pain. There is less evidence for SSRIs, so that is a typical serotonin antidepressant for anxiety and depression, but the data on DGBI is less consistent, and in fact, the American Gastro Association Task Force suggests against the use of SSRI. My personal opinion is that in the daily clinical practice, if you find that the patient has concomitant anxiety or depression, I think SSRI is really useful, so it needs to be individualized. There are some other less commonly used medical therapy or other modalities of psychotherapy that I will talk about this later. But for mirtazapine, I think I will discuss this in another slide, which is actually a very good drug for certain groups of patients with functional dyspepsia. So, well, if we are talking about neuromodulators and also psychotropics, well, they are certainly not the first-line treatment. But I think they are really useful for rescue therapy or for patients with refractory symptoms. And this is a clinical trial done in our center a couple of years ago. We focused on patients with refractory functional dyspepsia who did not respond to PPI as well as prophylactic agent. And we randomized them to low-dose imipramine, which is a tricyclic antidepressant, versus placebo. And we find that at the end of 3 months treatment, we find a significant higher response rate among patients taking tricyclic antidepressants versus patients taking placebo. So you can see almost a 30% therapeutic gain, which is actually quite a significant for clinical trials of functional GI disorder, thanks to the lower placebo response, and that's why we managed to see such a big response of therapeutic gain. But I think this is a very good data suggesting that tricyclic antidepressant could be used for refractory functional dyspepsia. And in this study, we also find that those patients with symptom improvement and response is associated with lower anxiety score. well, we cannot draw any causal association. It may be the pain reduction that leads to less anxious patient, but at the same time, this low-dose tricyclics may have some modest anti-anxiety effect, which leads to symptom improvement. Okay, so let me try to move on. Can I have the second slide, please? Okay, so again, this is a summary that I've just shared with you about the medical therapy for DGBI. Well, so these are the commonly used drugs. As I've mentioned, tricyclics remain the first-line treatment for pain. For SSRI, it is used mainly for patients with concomitant anxiety and depression. Whereas for tetracycline antidepressant, namely mirtazapine, which is a magic drug for a subset of functional dyspepsia patients with very strong nausea, postprandial distress, weight loss, and also insomnia. So this is a particular group of patients like ARFID, ASRID, which respond better to mirtazapine. For SNRI, which is a newer generation of antidepressants, well, there are more data suggesting this role for patients with pain disorder, like fibromyalgia, somatic pain syndromes, or more striking depressive symptoms. For this particular group of patients, SNRI may be more useful. In the daily clinical practice, I have another group of patients that I will use SNRI. That is the subgroup of breast cancer female patients who are taking tamoxifen, because well, venlafaxine is the only antidepressant that has no drug-drug interaction with tamoxifen. So I'm sure many of you might have seen this kind of patient. They have a lot of stress after combating breast cancer. Now they have emergence of DGBI. So for this particular group of patients, I think SNRI will play a more striking role. For the rest of this augmentation therapy, some atypical antipsychotics, I would incline to do it together with psychiatrists, because well, all these drugs need more advanced training or experience in order to titrate the dosage. So I won't recommend prescription of these medical therapies at the GI level. So I would suggest you to work together with mental health professionals for this group of medical therapy. So, well, before I prescribe this, I always reassure the patient that there is no concern about dependence and addiction. So antidepressant is not addictive. Benzodiazepine, sedative, hypnotics are addictive. And that's why I would reassure them to remove the stigma so that they are less resistant to this kind of medical therapy. But I just want to reiterate the negative vicious cycle because of self-stigma, frustration, and we keep reassuring the patient you have nothing, you are normal, but unfortunately the pain, the sufferings are real, and if you don't acknowledge this and plan relevant management, then they will just go ahead with the vicious cycle. So I think this is remains a very important message to learn. And before I finish, I want to briefly talk about the brain-gut behavioral therapy, which is an emerging modality of treatment. So GI psychology is actually an emerging field in the area of psychology, well, because it remains a very effective component of management in conjunction with medical therapy. So we have various psychotherapy that act on various facets of this vicious cycle of DGBI. So, well, I hope that in the future we can have a growing community of GI psychologists that can work closely with us for behavioral therapy. And there is good evidence supporting the role of behavioral and psychotherapy from this systematic review or meta-analysis, showing that therapist-based psychotherapy remains the best option of psychotherapy for these patients, with a significant benefit on reduction of the abdominal pain. So, well, in order to categorize how we deal with DGBI patients with psychological comorbidity, I would suggest use this algorithm. For those patients with pain predominant symptoms, apart from symptomatic treatment, well, we can be more liberal to use low-dose neuromodulators, and then further supported by behavioral therapy. For patients with more evident anxiety and depression, then in that case, SSRI will be the treatment of choice. But of course, you can take the liberty to discuss with a patient about mental health professional referrals. For patients with more selective GI-specific anxiety, again, apart from symptomatic treatment, I think GI psychologists may play a role in this aspect, apart from the medical therapy that can be useful. So in summary, ladies and gentlemen, I think there are very good positive epidemiological and biological evidence suggesting association between psychological factors and DGPIs. And that's why we need integrated management approach with therapeutic relationship, symptomatic treatment, early detection and intervention of psychiatric comorbidity, with a careful use of antidepressant modulators, but we need to be assured about patient the non-addictive nature, but also highlight the off-label use of this kind of medical therapy. And last but not the least, brain gut behavioral therapy is an emerging therapy. So thank you very much for your attention.